Welcome to the Summit PT Podcast, your guide to recovery, performance, and wellness. I'm Kevin Koska, Doctor of Physical Therapy, and today I'm joined by Kelsey Sivley. She is a Doctor of Physical Therapy and orthopedic clinical specialist and somebody who has an expertise in pelvic health. Pelvic health is an essential part of physical therapy, but is often overlooked. Whether it's postpartum from pregnancy, whether it's incontinence, whether it's pelvic pain, or even for males, post-prostatectomy. It can be a very effective treatment technique that, like I said, often gets overlooked. So I'm really excited to have Kelsey here with us today and giving the community here some good advice on the pelvic floor. So thank you for showing up today.
Thanks, Kevin.
Absolutely. So how did you get interested in pelvic floor therapy?
Well, I started my physical therapy career with going to orthopedic residency at Emory University to really up my game on my orthopedic knowledge, my interventions, try to get some structured mentorship, and I got all of that. And I started working at Summit Physical Therapy, which is my hometown afterwards. And I was in the Cleveland area, which is where I started, and realized that so many of my hip and low back patients were also dealing with complaints of urinary leakage or incontinence, urgency or overactive bladder symptoms, some of them complaining of intercourse pain or post-surgical pains that involved the pelvis or after giving birth. And I realized, oh my goodness, I'm missing the ball here when it comes to treating these patients by ignoring all the pelvic floor. And I thought I need to really get ahead of this and learn more about it so I can serve my community better and help these patients, considering they have a long way to go for any specialist in town, whether it be all the way up in Knoxville or all the way down in Chattanooga. And I wanted to fill some gaps in the community because there's not enough of us out there. So I started my continuing education journey with Herman and Wallace classes, got a lot of feedback, a lot of hands-on skills, internal and external approaches with my treatment interventions, and I feel like it's really upped my game when it comes to the orthopedic connections as well, because pelvic floor is ortho too, it's just in a more intimate area.
Yeah, absolutely. So what exactly is pelvic health physical therapy then?
So I usually describe pelvic health physical therapy by first describing where the pelvic floor is and what the pelvis is. It is a specialized type of physical therapy that is focused on all those muscles in the pelvis, as well as all the connections to the hip and the back. I usually tell people to think about where they're sitting right now and feel their sitting bones in their chair or on a hard bleacher. And if you sit way back, you can feel your tailbone pressure. And if you rock way forward and palpate just below your belt buckle, you can feel the front of your pubic bone. And if you think about between all of those bones where you're sitting, that bowl of muscles sits right in between them. And they hold up our organs. For women, it holds up our uterus and our bladder and our rectum. It helps us with respiration, men and women. It helps us with lifting and pushing and pulling, and it's the floor of our core, and it helps with a lot of different things like that, including sexual function and breathing patterns. So first tuning into where it is helpful, and then the therapy helps treat any dysfunction that is involved with those muscle groups or those bony landmarks, if that makes sense.
Yeah, absolutely. So we're kind of going down this road of what pelvic health is, pelvic therapy is. So what kind of conditions do you typically treat? I mentioned a couple earlier in the podcast, but could you go into a little more detail on what you actually do treat?
Yeah, a lot of different things, including urinary incontinence or fecal incontinence. A lot of people have heard of that, usually when it comes to pelvic floor physical therapy, of, oh no, I have leakage when I cough and sneeze or jump or push or pull. Very common ones, but some people it has more to do with urgency and not making it on time, or only when they run or kick a soccer ball. It really just depends on what's going on with that. Some patients we're working on pressure management for diastasis rectus abdominis, that is when the abdominals are separating between rectus abdominis at the linea alba. Sometimes we're working on heaviness symptoms or prolapse. What that means would be if the bladder is bulging into the vaginal canal or the rectum is bulging into the vaginal canal, depending on what's going on. Intercourse pain, that's another common one, or after postpartum, working on scar tissue from any tearing that might have happened during childbirth. Other common conditions could include coccyx pain or interstitial cystitis, sometimes endometriosis contributing to pain in the pelvic floor, and anything going on with the hips or the back as well, because that plays a big role.
So the referral comes, let's just say a patient goes to the doctor, they see the doctor, or they listen to this podcast, or they're online and trying to figure out what's going on, and then they finally come in the door and actually see you. What does that first evaluation actually look like?
Well, I try to be very comprehensive and thorough and look at everything that is connected to the pelvis, including the spine, the hips. I look at their knees, I look at their ankles, their neck, their breathing patterns, their rib cage. I try to do everything that I can externally as well, to look at how that might be impacting some of their symptoms. I also do an internal examination, assuming the patient is up for it on the first day. Sometimes we have to work up to it a little bit, but I take a lot of extra time to explain why I'm doing what I'm doing, why it's going to be helpful to best treat them and apply the interventions based on whatever exam that I find, exam items that I find. And I do a really thorough subjective history and medical history to look at everything else that might be contributing to their symptoms. But mostly we're looking at any kind of dysfunction going on. That way I can best tailor my interventions towards whatever deficits they have.
Okay. So the way my mind works is I try to organize things. And so I heard you say internal exam, and it sounds like you also do an external exam. And in some locations we do internal biofeedback, right? So that's the best way that our minds can actually learn is through biofeedback. It's the quickest way. Can you go a little bit more into detail for the listeners out there with internal versus external biofeedback? Yeah,
sure. For internal biofeedback, not everybody necessarily needs to do that, but if the patient has a lot of weakness or a very, very hard time being able to tune into their muscles to contract fully, to relax fully, or lengthen fully, it's very helpful to use my biofeedback device internally with a little vaginal probe that's inserted, and it connects to my little device that gives you a screen that shows you in real time what your muscle activity is doing when you're trying to contract, when you're trying to relax. And you can set targets to make it harder. You can set the duration and parameters to make it focused on endurance. If we need to focus on like urgency and trying to make it on time to the bathroom, or working on power, like a quick power flick whenever it comes to a cough or a sneeze or a jump or a push or pull. That's more power focused. So it just depends. Some people, I'm not even focused on their squeeze. I'm trying to work on getting that line to drop low so that they can fully relax their muscles, because they tend to be tense or holding tension or tightness the whole time. Eventually, I like to move away from the internal biofeedback and apply things out in the clinic more functionally when it comes to lifting and pushing and pulling, because that's where life is, right? Not on a table, it's lifting weights or lifting their babies or running again or playing sports. For the external biofeedback, I will sometimes just have patients use a mirror externally down there to watch the perineum lift when they contract, relax, and then bulge down, because you need both. You need to be able to lift and contract whenever you're trying to stop urine from coming out when you don't want it to. You need it to help with sexual function. You need it to help when you lift weights, to push, to pull with your hips, with your back, with your abdominal wall. And then you also need to be able to fully lengthen, elongate, bulge down, whatever synonym makes sense when it comes to like fully emptying your bladder or fully pushing out a bowel movement or just living at a relaxed state without straining or bearing down or adding a lot of extra pressure in the pelvic floor that doesn't need to be there. Hopefully that makes sense a little bit on determining whether you need to do the biofeedback or not. But I think sometimes if you've had surgeries or you've been cut through or you've had a pretty significant tearing or episiotomy postpartum, you need some help. Need a little bit of help, like tuning into those muscles again, just like you would externally to like your quadriceps after you've had like an ACL repair and you can't fire your quad and do a leg raise. Sometimes that electrical stimulation on that NMES setting or Russian setting can help you with brain-body connection to fire the muscles again. It's the same idea, just a more intimate area with different pelvic muscles.
Yeah, you took the words right out of my mouth. That's where my mind went, was straight to the quad following a knee surgery or something. Mm-hmm. So we've gone down the road of you've got the referral, or you've seen somebody for the first time. You've gone through some of the treatments, is what it sounds like. And then how does somebody know, hey, we're done. This has been a successful treatment. So you've taken us all the way up to the discharge almost now. Mm-hmm. From physical therapy or pelvic floor therapy. Can you tell me a little bit about, hey, we've come from here and we've made it all the way to here.
Yeah.
How do you know when it's time to discharge somebody?
For the entire plan of care.
Yeah.
It really depends patient to patient, goals to goals, and how many different things are going on how long that plan of care is going to take. It could be 6 weeks. It could be 12 weeks. Usually, if it's just incontinence, without a lot of prolapse symptoms or pain, the neuromuscular facilitation can happen quickly to start improving continence within 3 to 4 weeks even. And then I might, decrease the plan of care less frequent later on and make sure that I'm getting towards that working against gravity activity, because the bowl of muscles has to work a lot harder when you're standing than it does when you're laying down. And most people complain of having incontinence whenever they're standing or walking somewhere, trying to get in the house, versus if they're laying in bed, not usually as often. So I try to work them up to those higher level activities or get them back to their running. Some of those things take a little bit longer because we have to start with gravity assisted and then work towards against gravity and make sure they're doing everything correctly. And once they feel really confident and they've met their goals and everything, I feel good about leaving them on their own. If it's prolapse focus, it takes a good 10 weeks to move from one grade to the next, at least. Like if you had a grade 2 prolapse into the vaginal canal, it would take at least 10 weeks to move to the grade 1. And sometimes I'll space out the visits after that and make sure that the patient feels really comfortable working on things on their own. I'll set up some checkups 6 weeks after that, make sure everything keeps trending well. But usually, even if the prolapse is improved, but still visible a little bit, usually the patient feels really confident with returning to all their workouts and lifting weights again and lifting their ever-growing babies that keep getting heavier every single week.
Right.
And then getting back to the gym and feeling safe about doing it without making anything worse and having really good body awareness now. I think that helps a lot. Does that answer the question?
Oh, absolutely. Absolutely. So, I mean, in my world, from a strength standpoint, it takes 6 weeks just to show from the research just a little bit of what's called muscle hypertrophy, where the muscle fiber actually does grow. Does that mean you're stronger necessarily? Yes, but no. We want to see that muscle actually get bigger if we're looking at the quads or we're looking at the shoulder or anything else. So that gives the listeners, in my mind, an idea of how long a therapy session would take, and I think a plan of care would take. And I think when you mention just from a prolapse 2 to a prolapse 1,
right, then
that's at least 10 weeks. And when I'm seeing patients, I'm like, look, you're in here for at least 6 weeks. We can make the muscle, we can go from, I'm making this up, but from 2 pounds to 4 pounds on your leg lift. We can do that in 2 weeks, but that's just that neuromuscular re-education that we spoke about. That's just that the brain signal going from your brain to that muscle quicker now, more so than it getting stronger. And I'm sure you're very familiar with this. People think, oh, I'm already better, and it's 2 or 3 weeks later. But our goals as physical therapists is to find that root of that problem,
right,
and then get rid of your pain and return you back to function, but then make sure it doesn't come back again. So make sure that we have you strong enough. And I've always told my clinicians that, hey, I don't want them to be 100%. I want them to be 110%. I want them doing things that they never thought were possible, so that we can actually show that we're providing that value. Right. So I think that definitely answers my question, and hopefully it helps to shed a little bit of light onto that.
Right. The other piece of that is really helping the patient make a health behavior change to try to maintain what I've taught them for that 6 months. That's how long it takes to really get to maintenance. Even though, like you said, the neuromuscular adaptations have happened early on, if they stop everything that we've been working on, they're kind of regress back to where they were. So it takes some time, but I try to help patients feel really confident with that.
So with all those different diagnoses that we spoke about, from postpartum to prolapse to incontinence to pelvic pain, what do you feel like is the most common one that you see? And the second question to that is, what's the maybe the least common one that you feel like might be misdiagnosed, and that you often find come in the clinic and they're like, oh yeah, this is X, but then you do your evaluation, you spend that hour with them and find out, you know what, this is really coming from something else.
Right.
And let's just speak specifically to females on this.
Okay. I'd say the most common really is urinary incontinence. That is very, very common, whether it's postpartum or perimenopausal or at any age, really. That's the most common diagnosis I treat most, for sure. But usually my patients are dealing with multiple things at the same time. It's not just incontinence. They may also have heaviness in their pelvis and not sure why. And maybe they have never had anyone check to see if they had a prolapse or not. Some people are also dealing with intercourse pain and they can't figure out what's causing the pain. Is it hormonal, or is it muscular, or is it a referral pattern from the spine? Sometimes all of the things at once are happening: spine pain, intercourse, deep pelvic pain, heaviness symptoms, and incontinence. So it's kind of like, where do you start?
Yeah, really.
I really try to focus on pain first.
Yeah.
We get the pain better. We try to calm the nervous system down. We figure out what other factors around the pelvis might be contributing to all that tension in the pelvic muscles, including the spine and the hips. And then I can really target strengthening. Or I'll use a metaphor that helps sometimes of, like, think about a shoulder. If you were lifting a shoulder up in the air and it only lifts this high, and then you relax it down and it only drops this far, would I really want to give that shoulder a 10-pound weight to lift over and over again?
No.
And it doesn't apply functionally very well.
Right.
Same thing for the pelvic floor. A lot of people have been told by their doctors or whoever, just, you need to do Kegels, you're weak. That's why you have incontinence. And I think that's what's misunderstood a lot of times, is if you are doing that same thing with the shoulder in a very limited range of motion without good motor control,
or doing it incorrectly, right?
Incorrectly, yeah. It's not going to help much. You really need to make sure you're lifting all the way up with those muscles, relaxing all the way down fully, as if the shoulder was lifting all the way up, and relaxing fully before you add load to it and apply it more functionally. Otherwise, it's not really helping much. It might actually make them worse, depending on what's going on.
And that's where the physical therapist comes into play, to be able to assess that movement, the quality of the movement,
right,
and what the next step is, or do we need to reverse back and make sure that you know how to do steps 1 and 2 first before we move on to steps 3 and 4.
Right. The interventions need to be very individually tailored to each patient. Not everyone is treated the same. Kegels aren't everybody's friend. Sometimes,
and if you're doing them wrong, too, right?
Wrong. Some people, like I had an athlete who, she never had any children, and she was having leakage, and she had a grade 2 cystocele, which is bladder prolapse, and a rectocele, which is rectum prolapse, and she was only 18. Like, what's going on, right? Well, every time I saw her hitting the volleyball, she's really holding her breath and straining and losing her power, and like bearing down through her pelvic floor rather than sucking up and lifting. So all that extra pressure adds up over time, even small things, getting out of your chair, getting out of bed, and hitting a ball. Like, it depends. So we had to work on that for a while, but she got a lot better. But that's another example of someone who, like, their pelvic floor is impacting their sport, and it's not always having babies. Like, it could be very much a poor habit over time that needs to be addressed.
That's usually what gets us, right?
Yeah.
Our poor habits.
I'm right there with you, though.
So we've kind of went down that whole road. I'd love to hear, I mean, I've heard quite a bit, or at least 2 stories of some success stories.
Mm-hmm.
I always like to try to finish off these podcasts with a good success story. Do you have a good one that you can share with the community?
I do have a good one in mind. I have so many, but this girl was really trying to return to running marathons. Mm-hmm. And she was a prior marathon runner and half marathon, Ironman. Like, she was very strong. She had 2 babies. She kind of got out of her workout routine, some complications that happened during delivery. And then she ended up with that combination of symptoms like I was talking about earlier. She had leakage, just getting out of her chair. She's young. She's in her 30s. She had prolapse and heaviness, just standing all day. She was also working as a teacher, so she stood most of her day. I hate to put a label on the teachers and nurses, but a lot of them have some poor bladder habits because they got to hold it all day long, and they have a lot of increased tone and tension in their pelvic muscles because they don't get the chance to go to the restroom as regularly as they should, or they're rushing and force peeing and some other different habits like that. But for her, she had goals for returning to running without leakage, without heaviness pain, and we had to start slow. We had to start with working on deep trigger point release, whether it was teaching her how to use a wand to work on those muscles on her own at home, feeling what that should feel like, tuning into being able to breathe into her rib cage instead of all that pressure going down through the pelvis whenever she was exerting herself. She was dispersing the force a little bit better that way. We started with gravity-assisted activities whenever we were lifting, and then we worked towards standing activities. And eventually, we worked on power, which is essentially what happens when you run, single leg jumping over and over again, right?
Absolutely.
And she got back to it. It took some time. We used the biofeedback as well a little while. I tried to work towards against gravity. I had her doing some scar mobilizations and stuff early on too, and we had to make sure the load was optimal. If I was underloading her, it wasn't going to help. If I overdid it, we were going to add too much tension and pain, so we had to find that medium place. But she got back to it. She finished her whole plan. She's returning to running, doing marathons and everything, and all her goals are met. No heaviness anymore. She can do her work duties normal. She's got much better bladder habits now, which is great. And I think she's fully relaxing better when she empties, so there wasn't anything left to just leak within 20 minutes afterwards.
And those conversations that they have with you probably help too, because they're able to take that into their everyday life. For sure. But she did great. It was really warming to the heart to see her get back to all her high-level activities again. Absolutely. Yeah. Well, you're a wealth of information, and I actually learned quite a bit today. Yay. If somebody wants to learn more, how do they find you? Well, I always tell people to talk to our referrals coordinators at our main number, 423-777 4974. Yeah, almost have it memorized. And that one will help them determine which clinic would be best. I'm at the Ottawa clinic specifically, but we have another pelvic floor physical therapist at our North Shore clinic, and a physical therapy assistant in Saudi Daisy. I've got a physical therapy assistant that works with a lot of my patients with me at Ottawa as well. Or they can just go to summit-therapy.com and help find whatever is best for them, make sure their insurance is taken, and get set up for initial evaluation, and that can help a lot. You can see us without a doctor's referral as well for 60 days. It's very good to go ahead and get ahead of it and make sure it's appropriate for you to be seen by a physical therapist, and we can help refer you to the appropriate specialist if needed, if it's not appropriate to see us. But better to start now rather than let it keep going and limiting you with function and just dealing with it for years and years. It makes it harder too, right?
Oh, yeah, for sure.
The longer that it goes on, you probably find it. I mean, that's what I find in low back patients or knees or shoulders. It takes just that much longer to get them better if they've been putting it off and just thinking it's going to get better. Yeah, nip it in the bud early. Absolutely. Get started. I usually say try to see a pelvic floor physical therapist during pregnancy and after pregnancy. Don't wait till it's too late and you can barely get through your day because you're hurting so badly. Come earlier. It's much better.
even just to work on things ahead of time. Because if there is any kind of dysfunction going on in the pelvic floor, it's going to make itself known later in pregnancy, very, very commonly.
Just to get that whole area strong too, right?
For sure. It can even help with making delivery a little smoother. There's a lot that can be done.
Well, I appreciate your time, and stay tuned for one of our next episodes where we go into the pelvic floor for male patients.
Awesome.
So I look forward to chatting with you on that as well.
Thanks, Kevin.
You're welcome.